Well, good afternoon, all. Can anybody hear me? Give me a thumbs up if you hear me. Great. We're going to go ahead and start off the month of February. What? The first day of February 2021, talking through the international standards for the neurological classification of spinal cord injury. So hopefully no surprises on this. The residents have had this at least once each, and so as we go forward, I'll be talking through the revised version. That's the 2019 version of the INSCI examination. We'll talk through optimal testing for sensory and then motor, and then we'll talk about neurological level of injury, completeness, and the AIS impairment scale grades, as well as zone of partial preservation. So as it turns out, I've got 8 cases at the end, and what? I think I have 8 PGY2 residents. And so as we get to those cases, just keep in mind that each of you will be offered the opportunity to take one. And the earlier assessments are going to be easier than the later assessment. So what that's worth, if you want to volunteer, I want to put the expectations out there so that you know moving forward. So let's start through the sensory testing for the INSCI 2019 version. Remember that everything that you do with your sensory exam is going to be compared to the face. If there is no facial sensation present, then all the dermatomes below that will need to be scored as not testable. And we'll go through this again. We're going to be testing light touch, and we're going to be determining if the person has sharp, dull discrimination, so pinprick. We're going to be progressing caudally through 28 dermatomes on the right and 28 dermatomes on the left. If one of the key sensory dermatomes is unavailable, then you can use any spot within that dermatome, but you have to make sure that you note that in the comment box. The comment box is for those things that are different than absolutely standard, whether that's sensory or motor. So the sensory grading, you all know this, but either it's absent, or it's normal, or it's impaired. And we're going to talk through this for both light touch as well as pinprick. It may be not testable, and for example, this person may have a cast, a splint over the area, there may be significant scarring, there may be an absent limb, all of that to say if it's not testable, then you write NT for not testable. If you have a non-spinal cord injury condition present, so for example, you've got a peripheral nerve injury, you've got a brachial plexopathy, something along those lines, then you score it as you see it, but you put an asterisk beside it. And we'll be talking through that as we go. These are your tools. Remember that your clinical exam, when you're doing spinal cord injury, your clinical exam is more important than anything else. That is the basis for our classification for spinal cord injury. So you're going to be using a tapered wisp of cotton. So you'll pull out the little wisp on each end of I just lost the name of this, Q-tip. And then you're going to be making comparisons with the face. If they don't have sensation in the dermatome, you're going to list it as 0, that is absent. If it's normal compared to the face, then you're going to list it as normal. If they're not sure, you're going to test 10 times, and if the majority of those are, not just the majority, but if 8 out of 10 of those are present, then you're going to call that sensory intact or normal. And impaired means it's either hyper or less sensitive than the face. So with pinprick, we're going to be making comparisons to the sharp and the dull end of your safety pin. And we're going to be, again, comparing this to the face. 0, they have no distinction between sharp and dull. Okay, they may feel it, but if they can't distinguish between sharp and dull, it's still a 0. 2 means that it's normal compared to the face. It's just as sharp on the face, on this dermatome, as it is on the face. And a 1 is impaired. And again, this may be either hyper or hypo aesthetic compared to the face. If it's non-testable, you indicate it's non-testable. If there is a non-spinal cord injury condition present that doesn't allow you to test that particular dermatome, you put your score for what you have, and then you put an asterisk beside it. And so this is your INSCI examination sheet. You have the right side of the sheet, and you have the left side of the sheet. On the right side, with regard to sensation, you have light touch and pinprick, and you have 28 dermatomes that we'll be listing out here. So you'll list this for each side, and then we're going to talk through, but you're going to start reporting what you find in terms of your sensory scores down here, but you're going to have your sensory subscores listed here as well. So we'll talk you through that as we get there. The sacral component, remember, is going to be S3 is just over the ischial tuberosities, and S4 and S5 are as you go in towards the anal sphincter. So the dermatomes that you all know and love include C2, which is 2 centimeters behind the ear, right around the level of the mastoid process. C3 is in the supraclavicular fossa at the midclavicular line, and C4 is over the AC joint. As you continue down, we'll come back to C5 in a moment. C6 is going to be the dorsal surface of the thumb. C7, dorsal surface of that third digit in the hand, and C8 is the little finger, again the dorsal surface as we're looking through there. C5 is going to be essentially around the lateral epicondyle, and remember, as we look at these dermatomes, we're considering that the person is in a anatomical position, or at least that's the way that we would remember that we go lateral to medial on the upper extremities. T1 is going to be at the medial epicondyle, essentially. And then T2 is going to be in the axilla, totally at the armpit. As we look at the thoracic dermatomes, we look at the midclavicular line on both sides of the body. T3 is only scored as T3 if T1 and T2 are present and intact. So keep that in mind. Otherwise, remember that we have this cervical shroud, and sometimes the C4 dermatome can fool you into thinking that it was T3. But if T1 and T2 are absent, then you don't score T3 as present. T4 is at the nipple line. Again, we're looking at mid-axillary, mid-clavicular line as we're coming through there. T4 is at the nipple, T6 is the xiphoid, T10 is the umbilicus, and T12 is the inguinal ligament. And then you go halfway in between T10 and T6 is T8 to get your T8 dermatome. Halfway between T8 and T6 is T7. Halfway between T8 and T10 is T9. And then similarly, T5 is going to be halfway between the nipple line and the xiphoid process. So any questions before I continue on through the dermatomes? So we're going to look at below T12. The L1 dermatome is going to be lying midway between T12 and L2. L2 is at the anterior medial thigh, midway between the inguinal ligament and the medial femoral condyle. L3 is that point at the medial femoral condyle just above the knee. As we continue on down, we see the L4 dermatome at the medial malleolus. L5 is that third metatarsal midway through the foot. And then S1 is the lateral heel, and S2 is the midpoint of the popliteal fossa. Again, as we get into the sacral components, the S3 is essentially right over the ischial tuberosity. S4 is in the perianal region within 1 centimeter of the myocutaneous junction. So these are common sensory pitfalls. misinterpreting the patient's response, so make sure that you have good communication as you're speaking with them. Children under the age of 8, we should be using the we step. That's a separate element that we can discuss, I think, as we get into the pediatric didactics. If we are not explaining ourselves well, then we can't fault the patient for what they respond with. Discourage guessing. If they're not sure, just tell them you don't know, or have them tell you they don't know. If they are cognitively impaired, sometimes it's difficult to get a good sensory response. And then a delayed sensory response is difficult because you're not sure if they were guessing and just weren't sure. So go back and repeat it if there's a significant delay associated with it. So that was the sensory testing in a nutshell. The motor testing, again, is going to be for the right and left sides. You all know that essentially we use, this is also ordinal data, by the way, just as a reminder and a precursor to an upcoming lecture on statistics. The sensory exam scores that we report out, the manual muscle testing scores that we report out, these are considered ordinal data because they're ranked, but they don't have similar distances between them. So that a 0, basically from a 0 to a 1 isn't the same as going from a 4 to a 5 in terms of strength testing. That said, let me just jump back and say that we typically want to know if a person is less than gravity or anti-gravity. If they're less than gravity strength, then we're going to be assessing their ability to create any sort of contraction. If it's not visible, then we're going to grade that as a 0 for that particular myotome. If they can fire the muscle and move the limb through part of the range of motion, but not through the full range of motion with gravity eliminated, then we're going to score it as a 1. And if they can move the limb through a full range of motion with gravity eliminated, then we would call that a 2. These are all less than gravity. If you want anti-gravity, that is more than gravity, then we're looking at a person who's going to be able to move the limb through its full range of motion with gravity in play. So Isaac Newton would be happy with us at that point. If they can provide some resistance more than just against gravity, then we're going to score them as a 4. And if they have age and gender matched normal strength, full resistance through the full range of motion, then we would score them a 5. If they're in a cast, if they're missing a limb, that type of thing, then we would say that this is non-testable, NT. If there is a non-spinal cord injury condition present, they had, again, they've got a cast on their arm, you can't assess them fully through the range of motion, then you score them as you see it, and you put an asterisk beside it. So for example, if there was a peripheral neuropathy, if there was a brachial plexopathy in the upper extremities, you're going to score it as you see it, but then put an asterisk beside it because you don't think that the lack of full strength is because of the spinal cord injury, but because of this non-spinal cord injury condition. So the motor scores you're going to place, again, for the right side, for the left side, you have your upper scores with 5 different myotomes, your lower scores with 5 myotomes, and then we're going to report out to voluntary anal contraction. And so you're going to list these as we go through. Let's just talk through these different myotomes. I'm not going to spend too much time on these because I expect you all to know these, but if we're looking at the elbow flexors and we're trying to determine if the person can move the limb at all, then if there's absolutely no movement, no visible muscle contraction, we're going to grade that as a 0. If they can move it with gravity eliminated, but not through the full range of motion, we're going to give them a 1. So C5 would be the elbow flexors. We're going to support the forearm and observe, palpate the biceps to see if there's anything. What we instruct is for them to bend the elbow and try to bring the hand to the nose. So a grade 2 is when they're able to do that through the full range of motion. So for the elbow flexors, we would expect to be able to see the arm come through that full range of motion with gravity eliminated. When we want to compare, and they're lying down with regards to anti-gravity strength, so now they're going to have their shoulder neutral, elbow is extended with the forearm supinated, the neutral hand and wrist. You're going to support the wrist, but ask them to bend the elbow and bring the hand to your nose. If they can get that through the full range of motion against gravity, you grade that a 3. And then to grade it a 4 or a 5, you're going to essentially have a similar position, but you're going to have the elbow flexed at 90 degrees. We're going to ask them to hold their arm and don't let me move it. And you're going to try to assess whether that is age and gender matched normal, or if it's less than that. If it's less than that, you're going to give it a score of 4. If it's what you think is age and gender matched normal strength, you're going to rate this as a 5. By the way, no minuses, no pluses when we're talking about the INSCI examination. It's either a 1, 2, 3, 4, 5, or 0. Wrist extension. So again, you look at the position of the wrist. So you're looking at the wrist extensors. You want to have that in a neutral position, and whether or not they can move it through the full range of motion, you're going to score them a 0 if there's no contraction noted, a 1 if they can get it through a portion of the range of motion but not full range of motion with gravity eliminated, and you score them a 2 if it's able to move through the full range of motion with gravity eliminated. A grade of 3, you're going to hold them as they're showing here. Basically, the wrist is going to be from a flexed position. Ask them to move the wrist through the full range of motion. Bend your wrist upwards. Lift your fingers towards the ceiling. If they're able to do that against gravity, then you're going to score it as a 3. Again, to give them a 4 or a 5, you're going to ask them to fully extend their wrist, and then you're going to try to provide resistance. If it's age and gender matched normal, you're going to call it a 5 for maximal strength. If it's less than that, you're going to score it as a 4. The elbow extensors, again, we want to eliminate gravity, and you're going to be checking. I like to actually hold at the elbow with my finger over the triceps itself, the elbow's extensors, and ask them to straighten their arm. That way I can feel or palpate if there's any movement. But if they can't get it through, they can't move the arm at all, but you feel it, then you could score it a 1. If there's absolutely no feeling of muscle contraction or visible muscle contraction, you score it as a 0. If they're able to, with gravity eliminated, move their elbow through the full range of motion, then you would score them as a 2. Now we're going to be looking for anti-gravity strength. If they can, from this position, the shoulder neutral, adducted, and the shoulder 90 degrees flexed, if they can move their arm through the full range of motion, you're going to score it as a 3. And then you're going to provide resistance with the arm slightly flexed at the elbow. If they have age and gender matched normal, you're going to score it a 5. Less than that, you're going to score it a 4. The C8 myotome or the finger flexors, and again, you're going to put the hand in a position to eliminate gravity, and essentially ask them to bend the tip of the middle finger. So if there's no muscle contraction as they come, and you're going to stabilize the wrist, by the way. So if you see no muscle contraction, you grade it a 0. If there's some movement to the fingers, but not through the full range of motion, you're going to score it a 1. And if they can get it through the full range of motion, then you're going to score it a 2. So to look at anti-gravity strength, now you're going to basically turn the hand up and see if they can move the fingers against gravity through the full position. And specifically, you want to see the tip of the middle finger. You want to be completely righteous as you're doing this. As you look for a grade 4 or 5, basically, you're going to, again, have the wrist in a neutral position, stabilizing the MCPs and the PIPs. With the DIPs fully flexed, you're going to say bend the tip of your middle finger in this position and don't let me move it. So again, if it's age and gender match normal, you'll score it as a 5 for full strength. If it's less than that, you'll score it as a 4. And then we go to the T1 muscles. Those are the abductors. And so again, we will go with gravity eliminated. You're going to be putting the hand in a neutral position, the wrist in a neutral position, and ask them to move your little finger away from your ring finger or spread your fingers apart. If you don't see any movement, that's a 0. If you see trace movement, but not through a full range of motion, you're going to score that as a 1. If they can get it through the full range of motion, you're going to score it as a 2. If you want to look at anti-gravity, you turn the hand so that the little finger is closest to the ceiling, and you ask them to move your little finger away from your ring finger or spread your fingers apart. Able to go through the full range of motion, that's a 3. And then you're going to test for more than anti-gravity strength. So essentially the same position, you're going to ask them to hold the little finger away from your ring finger and don't let me push it in. If they can resist you in which you think is age and gender matched normal strength, then you'll score that a 5. If it's less than that, you'll score it as a 4. We're going to skip down to the lower extremity myotomes. Again, there's 5 of them that we're going to be reporting out for the INSCI examination, starting with the hip flexors. You're going to turn the leg out, have the knee essentially approximately 45 to 90 degrees. But what you want to do is to see if they can move with gravity eliminated the knee up towards the outside. So you say, move your knee out to the side. And if they aren't able to do this, if there is no visible muscle contraction and no palpable muscle contraction, you're going to score it a 0. If they can move it, but not through the full range of motion, you're going to score it as a 1. Again, you're going to support the leg in at the knee and the ankle. Ask them to move the knee out to the side. If they can get it through the full range of motion, you're going to score that as a 2. When you want to check for a 4 or a 5 anti-gravity strength, again, you'll have the hip 90 degrees flexed, the knee relaxed, and you will ask them to hold their knee in that position. Don't let me push it down. If it's age and gender matched normal, then you'll score it as a 5. If it's less than that, you'll score it as a 4. Knee extensors, so L3 primarily, the myotome are the knee extensors. Again, we're going to check it with gravity eliminated. Ask them to straighten their knee with gravity eliminated. If there's no movement, no palpable contraction of the quadriceps, you're going to score it as a 0. If there's some movement of the lower leg from the knee down, but not through the full range of motion with gravity eliminated, you score it as a 1. If they can get it through the full range of motion, and you're going to be supporting the distal thigh and knee, then you would score it as a 2 with gravity eliminated. To check for a 3, actually reach under the leg and put your hand on the opposite thigh, and essentially ask them to straighten the knee. If they can do it against gravity to the full range of motion, you're going to grade that a 3. To grade it a 4 or a 5 anti-gravity strength, you're basically going to, as I did here, put the knee in an almost completely straightened position. You're going to keep it flexed at about 15 degrees, and then you're going to ask them to resist you. So hold this position, don't let me bend your knee. If they can provide what you think is age and gender matched normal, that's a 5. Less than that is a 4. When we look at the L4 myotome, these are the ankle dorsiflexors. So again, you're first going to check those with gravity eliminated. If there's no palpable or visible contraction of the tibialis anterior, that is the dorsiflexors, then you would score that as a 0. If they can move the ankle but not through the full range of motion with gravity eliminated, you're going to score it a 1. you scored a 2 as you are supporting the leg under the knee and ankle. Ask them to lift the toes up towards the head, allowing the ankle to bend. And if they're able to get it through the full range of motion, then you grade that a 2. With looking against gravity, basically, you're going to support the leg under the knee and the ankle. Ask them to bend your ankle to pull your foot and toes up towards your head. If they can go through that full range of motion, you scored a 3. And then to assess for a 4 or a 5 anti-gravity strength, basically, you're going to ask them to dorsiflex the ankle, and you're going to provide resistance. You're going to ask them to hold your ankle in this position. Don't let me push it down. Age and gender, normal strength, you grade a 5. Less than that, you grade a 4. Recognize that one of the things that can fool you is great toe extension can be facilitated by plantar flexion. And so as you're doing this part of your examination, they may have some plantar flexion, which makes it appear as if EHL is present. Don't let them fool you. So to grade with gravity eliminated, basically, you're going to flex the knee at 90 degrees. Ankle and the long toe are going to be in neutral position. Support the leg and ask them to lift your big toe upwards towards the knee. If you see no contraction, you're going to grade it a 0. If they can move the great toe some, but not through its full range of motion, you're going to score it a 1. Again, now you're going to ask them from this position, basically to extend the great toe. That may sound confusing, so ask them to lift your big toe upwards towards the knee. If they're able to move it through the full range of motion, then you'll score that a 2. L5 myotome is essentially the extensor hallucis longus. If you want to know if it's anti-gravity, you're going to now move the foot into the position where they are actually going to be moving the toe against gravity. Ask them to lift the big toe upwards towards the knee. If they can get it through the full range of motion, you score it as a 3. To look at a 4 and 5, again, you're going to have the great toe fully extended and ask them to keep the toe lifted upward. Don't let me push it down. If it's age and gender match normal, you're going to call it a 5. Less than that, you're going to score it as a 4. And then when you look at the S1 plantar flexors, so this is your gastroc-soleus complex, again, eliminate gravity with the knee flexed at 90 degrees, the ankle supported in full dorsiflexion. You're going to ask them to point your toes downward like a ballet dancer. And if there's no movement, no visible contraction of the gastroc-soleus complex, you scored a 0. If they can get it partway through the range of motion but not fully with gravity eliminated, you scored a 1. Supporting the leg under the knee and the ankle, again, ask them to point their toes downward like a ballet dancer. If they can get it through the full range of motion, you score a 2. To look at, and this is one of the trickier ones, to look at grade 3 strength, basically you're going to have the ankle in full dorsiflexion, and you're going to ask them to push the foot down into my hand and lift your heel off the table. This is considered anti-gravity. And so again, you can see from the picture there, they've got basically the forefoot with their hands supporting it, and then asking the individual to push the foot down. You should see the heel rise through its full range of motion to give it a 3. When you're looking at grade 4 and 5, basically you're going to put them in a fully plantar flex position and ask them to resist you. Hold your foot pointed down. Don't let me push it up. So, so far, none of this should have been new to you. All of you have had this at least once, but recognize there are some common motor testing pitfalls. Again, the age of the patient, we would use the WE-STEP pediatric standards to check for children, and under the age of 8, we recognize there's going to be significant limitations. Again, discourage guessing. Cognitive impairment or language impairment may prevent a fully assessed examination. Lack of experience, usually this is on the examiner's part, not the patient's part. And so the only way you get better at this is by practicing it. And then go back and review those positions to make sure that you have them noted appropriately. Improper palpation, you may be feeling the wrong muscle. You may not check the full passive range of motion, and so that's going to be important for you to know if they got it through the full range of motion. Our folks, particularly as they have come out of spinal shock, may have some reflex withdrawal and spasticity that will throw off your examination. So I do range for somebody who I think has significant spasticity or spasms. I will passively range them before I actually do this part of the examination. Recognize that folks may be doing some muscle substitutions. So for example, if I'm wanting to test triceps and I don't have it completely stabilized, they can abduct the shoulder and fling out using the supinators, C5 muscle groups, essentially, to make it appear that they've extended their elbow, which would be a C7 motor. So be careful, make sure that you're stabilizing joints appropriately as you're doing this. Did I mention you don't write down positives and negatives on the INSCI examination? There are some optional motor testing. So these are non-key muscles. They will be listed as NKM, and you would do this in the event that for some reason you don't think the usual myotome muscles are working appropriately. So we've got these listed out for each of the myotomes in the upper extremities and lower extremities. This will help you to determine if a person is truly motor complete or if they have some motor function. And so keep these non-key muscles in mind when you're trying to discriminate between Asia Impairment Scale B or C. And then as we get down to the S4, S5 myotomes, basically, this is going to be with voluntary anal contraction, and we'll talk through this a little bit more so. The other thing, deep anal pressure is actually part of the sensory exam, but I'll come back to that as we move forward. So common anal rectal testing pitfalls. The same things that we had discussed before, lack of experience or a very tense patient, all may contribute to inappropriate reporting of what is truly sensory or voluntary motor function. Recognize that when you're trying to determine if they truly have voluntary anal contraction, as you move a little bit, that can cause reflexes. And so particularly we want to be careful not to report a reflex response. Make sure that you've got everything settled down and then ask them again to contract the anal sphincter. They may also be increasing intra-abdominal pressure, and you may experience that or think that that is a voluntary anal contraction. They may contract the gluteal muscles. What? Those are S1 or L5, and potentially could fool you. And so recognize that you really do need to be very, very careful as you're doing your anal rectal. You need to be anal and make sure that you're doing it appropriately. So I'm going to talk you through the steps in classification now. The first step is going to be to determine the sensory levels for the right and left side, and that includes light touch as well as pinprick. So we're going to be going through all of these dermatomes, and you're going to be reporting them. This column represents the right light touch, and this column here represents the left light touch. Recognize that you're going to be reporting these under light touch right, light touch left for the total. A maximal score for one side is going to be 56. The opposite side also 56 is your possible, your highest possible dermatomal score for light touch. You're also going to be looking at pinprick and reporting that out for all 28 dermatomes. As well, you're going to report those out on this portion of the form. Remember that deep anal pressure is actually part of the sensory exam as well. Once you've done your sensory exam, you're going to move on to your motor exam. want to make sure I'm not too far behind here. And again, we're going to be reporting this out on the right and left sides. You've got 5 key myotomes on the right upper extremity, 5 key myotomes on the right lower extremity, and you're going to be reporting those out as well under the motor score subscores as we talk through those. So you put those scores in there, 0 to 5, so that your total score on the right could be, let's see, this is 25, and this is 25, and that would be 50, okay? And then similarly on the left, you're going to report those scores out, motor scores. So your total score on the left side would be 50. Your total motor score could be 100 as we're going through that. So keep those in mind. Your total sensory score couldn't be more than 112. And then we determine the neurological level of injury. Remember, this is going to be the most caudal segment where you have normal, that is 2 dermatomes, and your myotomes are going to have to be at least a 3, with the myotome above that being a 5. So as we put these together, you're going to be looking through and listing your neurological level of injury. Essentially, this is the most caudal portion that you have complete normalcy. The myotomes can be anti-gravity as long as the myotome above them is a 5. Now, if you're at a C5 level and you're trying to report out your myotomes and to determine your level of injuries, keep in mind that C4 has to be, you don't have a motor or a myotome, so the motor above that has to be normal, that is 2. The only way you know that, I'm sorry, is that your sensory for light touch and pinprick has to be a 2. If it's less than a 2, if this is a 1, for example, at C4, and this is a 5, because this is not normal, you would still have to go to the point above that to determine what your myotome was. Then determine whether the injury is complete or incomplete. And so again, basically you're looking at this line on the INSCI examination form. You want to determine the absence of sensory and motor function so that you would report out no sacral sparing. You're going to be reporting this as incomplete if you have any sensory sparing there. So if you have a sensory or motor spared below that level, you're going to be reporting this. Remember, you're looking for the noon sign. We'll talk through this in a moment. Motor incomplete, we've talked through. The noon sign we'll see as we report out our final scores. And then you're going to want to determine if this is incomplete. We're going to make determinations on whether this is a B, which is sensory is intact but not motor, below the level of the injury. You would call it an AIS Impairment Scale C if you have some motor function below the level of the injury and the majority of muscle groups are less than anti-gravity. If the majority of muscle groups are greater than anti-gravity, then you're going to report that as a D. So if you have greater than anti-gravity strength, for example, on the majority of muscle groups below the level of the lesion on one side, you already know that that's going to be an AIS Impairment Scale D as we're talking through. So sacral sparing, very, very important. Looking for the noon. If the noon sign is there, that is you have no voluntary anal contraction, no deep anal pressure, and you have zeros in the S4 and S5 dermatomes on both sides, this is a complete injury, AIS Impairment Scale A. All right. So if you have an incomplete injury, that means you, if it's a B, AIS Impairment Scale B means that you have sensory spared but no motor spared below the level of the injury. An AIS Impairment Scale C means this is motor incomplete, so now you have Less than anti-gravity strength in the majority of muscle groups below the level of the injury, but you do have some motor sparing. Asia Impairment Scale D. This is motor incomplete, but more than anti-gravity strength in the majority of muscle groups below the level of the injury. Asia Impairment Scale E is all motor and sensory is normal. So you have all 5s on your motors, all 2s on your sensories. Why would you even report that? Because you probably still have spasticity, disinhibition of those inhibitory pathways. And it's important to report even an Asia Impairment Scale E, because the person is still at risk, as you all know, for detrusor sphincter dysinergia that could potentially kill them. So we need, and their spasticity may impair their gait as well. And then finally, the last part of the examination is to determine the zone of partial preservation. So that's previously, that's only been reported for complete injuries. But as of 2019, we're going to report zone of partial preservation for incomplete injuries. To report a motor zone of partial preservation requires absent voluntary anal contraction. If the voluntary anal contraction is present, if this is yes, then you have to put an NA under the motor zone of partial preservation. Similarly, for sensory zone of partial preservation, you have to have absent deep anal pressure. So as you look over at this side of your form, if this is no, then you can report it out. But if you do have deep anal pressure present, then you can't report out the sensory zone of partial preservation. We'll run through those a little bit more as we get into our assessments. I don't want to run out of time here. So tagged scores, and again, this means the asterisk goes alongside those. You perform this on the basis of your exam and scores, and you grade what you find. And then you put an asterisk because you think that this score is unrelated to the level of the spinal cord injury. It's a non-spinal cord injury problem. And so you'll put that down there as you go. So case 1, I'm looking for a volunteer. I think I have 8 residents who are PGY2s. Remember that the first cases are going to be easier than the last cases, and so you might want to. Who volunteered? Was that Dr. Acosta?
It is Dr. Acosta.
All righty. So walk us through this case 1, and remember that I'll kind of ask for specific things as we go through here. But tell me what you think the sensory level is and why.
Sure. So I will say that the sensory level is C6.
And why is that?
Well, C6 is the last sensory level where there is any sensation. So C7, there's nothing. It's
okay.
0 all the way down on the left side and on the right side as well.
Okay. Good. So what do you think is a motor level?
So motor, if C7 were 3, then I could say the C7 is, but it's not. So it has to be C6 because C6 is a 4, and then the level above that is 5.
Okay. On the right side and the left side?
Yes.
Okay.
Yes.
Correct. Okay. So we'll call that our motor level. What's your neurological level of injury going to be? Remember, that's your last normal motor and sensory function.
C6.
Okay. We'll move forward and tell me whether this is a complete or incomplete injury.
So I do see the noon sign. So that is a complete injury.
All righty. And so your Asia Impairment Scale will be?
C6 AIS A.
All right. And can you report out zone of partial preservation? Is your anal contraction negative? Is your deep anal pressure negative?
They both are negative.
Okay, so you could report out sensory and motor zone of partial preservation. Your sensory zone of partial preservation would be,
I guess C7.
well, you really don't have anything
Yeah.
spared at C7. So you're just going to
Yeah.
report out C6. And your motor level,
The motor could be C7.
okay, because you do have some motor function at C7.
Right.
Okay, so let's see how you did. Oh my goodness, you got them all. Dr. Costa, strong work. That was a really hard case, but now they're going to get even harder. So who's up next? Anyone? You're going to have to speak up. I can't hear anybody volunteering.
I can go ahead and try.
And this was Maja?
Yes.
Dr. Mzambwe, welcome.
Thank you.
Let's move on to case 2. I'll give you a little bit just to take a look at it there, but recognize that the first thing I'm going to ask you is, what do you think the sensory level is?
All right. So sensory level, the last area that.
Tell me about sensory level on the right.
On the right, I see the last normal is C3.
Okay, and on the left?
On the left, it's going to be C4.
Okay, that's
so
done. Tell me what the motor level is.
so for the motor level on the right, I see a 3 at C5, and then a 4 at
Okay.
C5 on the left.
Before you go on, because I want to make sure that you think through this, to
Yes, sir.
have this a 3 and call it C5, what do you know above that? Above that has to be normal.
Above that has to have a normal, also 3, at least.
Okay, so since C4 is not listed as 2s, what would you have to
Okay.
call your motor level?
Then I would have to go above, and it would have to be a C3.
Okay, so on the right, it's a C3, and on the left,
Okay.
not quite so tricky.
And on the left, it's C5.
Okay.
Yep,
Okay,
C5
C4 is intact,
is intact, correct?
and C5 is greater than a 3, greater than or
Correct.
equal to a 3. Okay, so your neurological level of injury is going to be,
C3.
all righty, and is this going to be complete or incomplete?
All right, so no to deep anal pressure, no to anal contraction, so that makes it a complete.
These are zeros, so noon is present. So
Okay.
you're going to call that complete, and your Asia impairment scale is going to be?
Asia impairment scale, so a C3 AIS complete would be what I would describe it.
But would you list it as Asia impairment scale A, B, C, D, or E?
So for Asia impairment scale, I would list it as A.
Alrighty, and then looking at zone of partial preservation, do you have absent deep anal pressure and voluntary anal contraction?
So there's no area of partial preservation.
Remember, if these have to be absent. If they're present, then you can't put your zone of partial preservation. But if you have no deep anal pressure, if you have no voluntary anal contraction,
Okay.
then you would report out a sensory and motor zone of partial preservation. So sensory on the right would be?
So sensory on the right, in terms of intact sensations, at C4, but there is ones at C5, I see.
Okay, so what are you going to say the zone of partial preservation is for sensory on the right?
On the right, I would say C4, on the right, it would be C3 is the only area.
Do you have
that's
any
intact.
sparing at C4 or C5?
Some sparing at C5 and C4.
So if you have some sparing, then I would use that level to determine or to list out as your zone of partial preservation. Okay.
Okay, so up to C5 on the right and
On the right.
C4 on the left. No, looks like C5 bilaterally for zone of partial preservation.
Okay, and how about your motor function? do you have motor function spared below what you called your motor level of injury?
Yes, so on the left, there's still some motor function all the way to C6, and on the right, C1, wrist extensors, has some motor function.
I'm sorry, I misunderstood you perhaps. I heard that you said motor zone of partial preservation on the right was
So
C6?
on the right, it'll be C6.
And on the
And
left?
then on the left, it would be a C6 as well.
Okay, let's see how you did. Very good. All right, are you guys catching on to this now? So let's move on to our next volunteer. Did I mention these are going to get harder as we go? Nobody's going to volunteer? Otherwise, I just have to assign it.
I'll give it a try.
Okay, who was that? Was that Nathan?
That's Nathan McKenty here.
Dr. McKenty. Well, let's see. We're moving on. Oh, case 3. Help me out here. What would you call the sensory level for this case?
Sensory level here on the right side will be T12. Sensory level on the left also be T12.
And what would you call the motor level?
Motor level for this patient. Right side, no, is T12. Left side, also T12.
All right. What would you call your neurological level of injury?
So the level of injury in that case would be T12.
All right. And would you call this complete or incomplete?
We call this incomplete
Why would you call it incomplete?
because we have some preserved motor function on the left below the neurological level of injury.
Is that where you go to determine if it's complete?
No, we have sensory function preserved as well.
But where do you go to know if an
Oh,
injury
sorry.
is
So we have the deep anal pressures is yes.
Okay, so I'm trying not to give you too many clues here, but
Right.
remember you go down to this S4, S5 level and you look across here, and if you don't have noon, then it's an incomplete injury.
Right.
And so you've determined it's incomplete. What would you call your Asia impairment scale?
Let's see. The Asia impairment scale B, I think, because of the preservation below T12.
Okay. So anything else you want to consider? Do you have motor function spared 2 or more levels below the level of your injury, your neurological level of injury? You told
Yes.
me that you have deep anal pressure, so that's sensory. Do you have motor spared below that?
I have at least one in L3 and L4.
All righty. So would that still be Asia impairment scale B?
I guess that makes it C then.
Okay. You guess, or you're saying for sure?
No, it's C. It's C.
All right, I see. And zone of partial preservation, can you report it out for sensory? Is
For
this no?
sensory, zone of partial preservation, on the right, on the left, down to L4.
So before you answer me, let's back up a step. Remember that if this is yes, then you don't report out sensory zone of partial preservation. If this is anything but no, okay?
Right,
And then you look over here for motor. Motor is no. So could you report out zone of partial preservation for motor?
motor to L4.
Okay. And are you asking me or are you telling me?
With the period.
With a period. All right. On both sides.
Only on the left.
Oh, so what's the motor zone of partial preservation score on the right?
I guess they're, well, it's T12.
Let's see how you did. Is this starting to make sense as you're coming through? All right.
Slowly.
Well done. Let's go through a couple more. I need the next volunteer. before I show it, I need.
I'll go ahead.
Who jumped up there?
Read yours.
Okay, I saw hands moving, but tell me who's doing this.
Read Yaris.
Dr. Yaris, you're
My
disguised
computer's
as
not.
you're disguised as Jose Vivas, but
I am Jose Vivas today.
he is a friend of mine. No, wait, that's an old song. Let's get a feel for your sensory level for this individual.
T12.
All right, and are you telling me on both sides?
Bilaterally. T12.
Okay. How about your motor level?
Bilaterally. T12.
T12. What about your neurological level of injury?
T12.
You really like this whole T12 thing, don't you? So tell me, is this a complete or an incomplete injury?
I see a noon sign. This is complete.
All right. And what would you call the Asia impairment scale score then?
Asia impairment scale. A.
And you're sure?
T12.
Well, the Asia impairment scale is A, B, C, D, or E. And so tell me about zone of partial preservation. Can you report it for sensory?
I can record it for sensory because I have a deep anal pressure.
Okay. And how about the patient? Does the patient have
On
deep
the
anal pressure too?
on the right, it's T12. On the left, it's L4.
All righty.
It also has voluntary anal contraction. Does
It
not,
does
so
or
I could
doesn't?
do a motor level,
Okay.
which is T12 on the right. Sorry.
And motor on the left?
And T12 on the left.
Are you sure? Is there any motor
No, it's
sphere?
L2 on the left because there's a 2 there.
You are good.
I just really
So-
like T12.
So this is how you do it. Nicely done. So I've got Dr. Yaris down. I'm down to 4. Who's going to go next?
Should I try?
Anyone? Who's speaking up?
George, hello.
Oh, George, I'm so sorry, but I'm only going to pick on resonance. You were an experienced INSCI examiner, but I thank you for your willingness to step up.
Thank you.
I've got 4 residents left. Do I need to assign these?
I'll go for it.
Who was that?
Dr. Madhu.
Dr. Madhu, welcome. Let's move on to case 5. Take a look and tell me what you think the sensory level is going to be.
Sorry, I didn't hear what you just said.
Sensory level
Sensory level, okay.
on the right and then on the left.
The right, C7.
This is the right, and you're going to call it C7. And on the left,
C6.
okay. Tell me what you think the motor level is.
The motor level on the right, also C7 because above it you have all 5s.
Mhm.
And then on the left, call it C5.
Are you sure that's what you want to call it?
Actually, no, call it C3 because you have C, yeah, or sorry, C6 because 6 has at least a 3.
Okay, so what are you going to call it? Give me your final answer. For motor.
For
Right
motor,
side. Right side motor is,
right side motor is C6. No, sorry. Right side motor is C7.
okay. And
Left.
the left side motor is
Left side motor is C6.
C6. Okay. So what's your neurological level of injury? Where is it? Everything normal and or anti-gravity?
C6.
All right. Final answer?
Yes.
Okay. Is this complete or an incomplete injury?
This is an incomplete injury.
Okay. And how incomplete is it? Is it Asia B, C, D, or E?
All right, so calling this C6.
So first tell me if it's a B or a C.
I think it's B because C. Call this C6.
Not trying to
Yeah.
give you any hints here.
Yes.
Yes, what? Yes, it is complete? Or yes, it
No.
is a B?
No, it is not complete. Yes, it is B.
You're sure it's a B? Do you see my cursor moving at all?
Yeah, I see circling a yes on the voluntary anal contraction.
And a voluntary anal
Oh, if
contraction.
they have that, then it's so it's gotta be C.
Was that an absolute C or was that a B?
I was thinking B initially, but now I'm thinking C.
Okay. And what would you say about zone of partial preservation? Can you report it out for sensory? Remember, if you have deep anal pressure, you can't report sensory
Okay, so we
zone of
don't have
partial
it.
preservation. And
Yeah.
if you have voluntary contraction present, you can't call the zone of partial preservation motor.
So we can't call it for either then.
Are you asking me or telling me?
Telling you,
Okay,
no zone of partial preservation.
strong work. All righty.
So it's
So look, you survived this, but there are 3 residents left, and I know that we're almost out of time, but I'm going to do it anyway. So I've got, who is it? Alyssa. I haven't heard from you. Is Alyssa here today? Anyone?
I can do it. I can try.
Alyssa, you know, I've hardly ever spoken to you, so this will be nice.
What did he say? Oh,
So
my
this
God.
is,
I can't do this. A brachial plexus injury?
you can do this.
Okay. First
All I can see is the top of your head, so just do it off the top of your head.
So sensory on the right is going to be T11. That's the last tooth. Sensory on the left is going to be T11 too.
When you say T11 2, do you mean T2 or T11?
T11 as well.
Okay, so that's your sensory. Tell me about motor. What are you going to call the motor level?
Motor, it would be also T11 on the right, correct?
How about on the left?
Also T11.
So are you asking me now or are you telling me? Do you believe what you're saying?
Not really, but yes.
Okay, so we're going to say T11 for the sensory level, T11 for the motor level bilaterally. That's what I heard.
Yes.
What's the neurological level of injury?
T11.
Wait. Are you telling me or asking me?
I guess I'm telling you.
Okay, so say it like you're telling me.
T11.
Good. Now, is this a complete or an incomplete injury?
It is incomplete because we have deep anal pressure.
Wow, that was assertive. I like that. And how about the Asia impairment
Okay,
scale?
this is what I need help with. I don't get this. So there's no 3s in the lower extremity. And we have deep, he doesn't have voluntary anal contraction. So it's a C because he has motor, but
2 levels below T11, like L203 has motor, so it's automatically a C.
even though they're not greater than a 3.
Correct.
Okay.
Correct, because he's got some.
If you have any motor sparing below the level of injury, or I should say below the level of injury, and you have some sacral spared, then you could call that
C.
Asian impairment scale B or C.
C based on.
Yes, that was assertive. And tell me about sensory zone of partial preservation. Can you give me a score?
I cannot because we have deep anal pressure, so it's not
You're
complete.
getting very assertive now. And how about on the motor aspects of things? Can you give me
The-
the motor zone of partial preservation?
I can, and I think it's L3 on the right.
Wait. This inflection with your voice?
It's L3 on the right.
Yes. And how about the left?
Also L3.
Strong work. Nicely done.
Okay.
Did she live through this? I can still only see the top of her head, so I'm hoping that she didn't pass out there. We have two more residents. Let's see. Oh, Dr. Gouda. Is Dr. Gouda here? Is Dr. Gouda?
Yes, yes.
Oh,
I'm
yes.
off camera. I'm answering. Let's do it. C7, case 7. We're gonna start with sensory on the right. That's gonna be a C6 on the left. That's gonna be a C6. Motor on the right, C6, and on the left, also C6. Neurological level of injury, also C6. Complete or incomplete? It is incomplete because we have deep anal pressure.
So you're moving a little fast for me.
On the left motor.
Left
Remind me about motor on the right.
C5, excuse me, C5.
Okay.
Yeah, you're right. Yeah.
Tell me about neurological level of injury.
That's gonna be a C5.
Okay.
Incomplete due to deep anal pressure being intact. Asia impairment scale. Let's see. That's gonna be a B. B as in boy.
Are you asking me or are you
No
telling me?
inflection, very firm. Boy, B as in boy.
This is a B as in boy.
Yes.
Okay.
Zone of partial preservation, no sensory, but motor. We have C6 on the, no wait, no. Yeah, C6 on the right, and then C7 on the left.
All righty. Now, tell me what I'm seeing here.
So I guess that's not one of the typical muscles, so.
It's a non-key muscle,
Yes.
and yet the person was able to activate this consistently. And so we put it in this box. Always look to this box before you give me an absolute answer. And if I was to tell you that there are adductor muscles activating, what level is that approximately?
That's the obturator nerve. That could be L2, 3, 4.
So 3-ish,
Okay, I'll
Yeah.
double check on it.
which means that you've got some motor spared. And hence, instead of calling it a B, we would call it a C. Does that make sense?
Yeah.
This is where you get focused on these things. I'm just warning folks, don't forget to look in the box.
So I guess like would the patient like offer that to you? Like, oh, I could still do this though. Because normally you wouldn't test that.
Yeah, so when I'm testing them, I say, is there any movement at all that you have below the level of the injury if they've come up with zeros on these others? And I
Gotcha.
could ask them for the specific myotomes in these non-key muscles. All right,
Gotcha. Thank you.
you bet. Let's see, that leaves Dr. Amarianfar. Is he anywhere nearby?
Present.
Yes. Nice. So that leaves you with our final one, and I know I'm running late, but let's just go ahead and do it anyway.
All right, so we'll start with the sensory level. I'm gonna go with. Wait, this is on the right, right?
So on the right side,
This is right. Oh, sorry. So on the right, the sensory level, I would say C5.
you would say it or you're saying it?
No, I am saying it. Excuse me.
Okay.
Firmly.
How about on the left side?
Ooh, on the left side, I would say all the way down there. That's 4 or 5, right?
So what do I write in this box for sensory?
Oh.
No, not O. That's incorrect.
So I say, I'm going to say S4-S5 for that one.
You're going to say that.
Yes, I am. That's my firm answer.
Uh-huh. How about if I just say INT? What does that stand for?
Oh, intact.
Intact. Oh,
I like that. I like that.
Okay, let's go on to motor.
Alrighty. So for motor, on the right, I'm gonna say,
You're gonna
yeah,
say, no,
it has
just
to be
say it.
C6. So I'm gonna go with C. It is C6. That's my answer.
Okay,
And then on the left, I'm going. It is going to be T1.
it is going to be, or is it now?
No. It is T1.
Okay, good. And tell me about your neurological level of injury, or at least for this patient. Where is everything normal?
Right. Everything normal. It has to. Sorry. It is C5.
Okay. And are you calling this complete or incomplete?
I'm gonna say this is incomplete.
When are you going to say it?
Now.
Okay, go ahead.
It is an incomplete spinal cord injury.
Okay. And tell me about the Asia impairment scale.
Asia impairment scale is. So 1 second, let me just think it out real quick. So we have, oh, wait a minute. There's a tip fracture, 1 plus there. So I'm not going to include that. So I'm going to say it is it's a D, right? I'm going to say D.
When are you going to
No,
say
it is D. It is D.
Okay, good. And tell me about zone of partial preservation. Can you give me a zone of partial preservation for this person?
No, I don't think we can. Oh, I know we can't.
Strong work. I just need you to you and Alyssa, I would just encourage you. In fact, I encourage you now to be assertive and don't say I'm going to say, but say this is what it is.
Right. It was at S4, S5. That one really kicked me in the butt.
And you could feel it. Alrighty. So these optional testing things are listed in here. I'm going to jump ahead because I've got to get to clinic. And so these handouts are available to you, or I'll make them available to you through Caritha. But just kind of keep them in mind. I'm excited that all 8 of our PGY2s got through this. Of course, you did have Dr. Vivas there, who could have provided you a consult if you had only asked. But in the future, we will talk through what's our next point of discussion. We should probably talk about prognosis next. What type of recovery do we anticipate a person with spinal cord injury is going to have? So that will be my next presentation to you. Everyone have a wonderful day. Hopefully this clarified and didn't confuse things. All righty. Bye all.